So the first part of the talk today really is just to set the platform for others to expand on. And this is just really just making the point that if you look at global burden of disease and look at mortality rates, actually COPD there is number 3. In fact, interestingly, lower respiratory tract infections, number 4, most common cause of death worldwide. Lung cancer, 5th, and actually TB still here, showing you that third world countries suffer mortality from conditions other than those that we do. But it's right up there, so it's an important area of endeavour, an important area that requires our more closer attention. Now, if you actually look at the years lost to disability, then here we have asthma because of its prevalence. 10 to 20% of the population in New Zealand has asthma, and COPD being the most common causes of disability amongst New Zealand men, and in fact higher than diabetes. And then you've got anxiety and depression, which are, as we all know, very important causes of disability as well. And one of the things we're going to stress today in our talks is the fact that it's important to reflect on the multidimensional components of care and the fact that there's often comorbidities and that patients often have problems with anxiety and depression, particularly as their chronic medical conditions, including COPD, become more severe. For females, it's depression and anxiety actually hit it, but asthma and COPD are high there as well. So they're important areas of concern, and there are areas that we need to try, I think, and do better in. This is just a table from the OECD database, or it's actually a figure, and it's just pointing out looking really at avoidable hospital admission rates, because we think about COPD and asthma admissions, that at least half of those are potentially avoidable. So it's nice to see somebody wanting to look at managing them more in the home, and we've got robots in the home for COPD patients, so we can talk about that later on. But New Zealand figures for asthma and COPD are poor, 4th highest of all the OECD countries for admission rates for both asthma and COPD. It's not just that we have a fragmented or that we don't have universal healthcare, because our diabetes and congestive heart failure admission rates are actually some of the lowest in the world. So we could be doing better, I think, in relationship to COPD and asthma. And the only way we're going to do better is to look at it as a sort of a more systematically, I think, as well as looking at the individual patient. This is just to expand the theme further. We were asked to talk about COPD today, and I was keen rather to lump all of the inflammatory airways disorders together and talk about them as a continuum, and you'll see why as my talks unfold. But here's data on admissions to Middlemore Hospital over the last 10 years, looking at these 3 diagnostic groups. And you can see for bronchiectasis, half the time they get labelled as having bronchiectasis on admission, and half the time they're labelled as having either asthma or COPD, or even a combination of those. And same with asthma. A lot of the patients who are labelled as asthma, actually about 1,000 of them get relabelled as bronchiectasis. So there's a lot of overlap between these patients, and that's not surprising. And you'll find out more as my talks unfold later today. So it is important, I think, for us to consider them as a continuum, and just to also reflect on the fact that, if you've had asthma since childhood, by the time you get to 65, there's a very good chance you're going to have some fixed airways obstruction in association with that, and you're going to end up being labelled as COPD. My second part of my talk is really to look at biomarkers and how important they are in terms of evaluation and management of patients with inflammatory airways disorders. And to my mind, that's more important to think about them and to think about the biomarkers and what the inflammatory cell is that's present than to spend a lot of your time trying to put them into a little box with a name on it. So historically, we've talked about atopic asthma being on this side of the equation, of course, bronchiectasis on this side. These guys have got infection present in the airways. These guys have got allergens and eosinophils present. And you can see at the top here, I've got a lot of eosinophils. It's eosinophil predominant, but sometimes neutrophils are in their airway, and we need to reflect that. On the other hand, these people at this end of the spectrum more frequently have neutrophils in their airway and infrequently have eosinophils. And that, you'll find out later in my talks, the relevance of that as well. So now I'm just going to sort of expand it out further and say, well, look, when we're looking at the person in front of us who's got so-called asthma or COPD, we need to just reflect on that fact that they are part of a continuum, possibly, but we also need to think about them in a more substantive way. So, you know, this is most of what I'm going to talk about today is looking at them in relationship to how do we target drugs better to manage their airways disorder. But we also, all of us, should be using guidelines more to underpin the way we manage them. And I'll outline why that's important as well. If you go out in the GP land, you find 3- or 4-fold variation in the way we're managing patients with inflammatory airways disease. And when we did an audit of DHBs about 10 years ago, we found 2- or 3-fold variation, even across DHBs in a number of these parameters. So we're not very consistent in the way we're administering our approach to these conditions. So my theme is that I think we should have clinical pathways. We've developed an electronic clinical pathway for COPD, and we plan to do that for asthma as well in Auckland, and to evaluate that in primary care if we can get some funding from HRC. The other thing is that people who have COPD and people who have late onset asthma or asthma that turns into COPD have increased risk for developing other conditions. People with COPD are at increased risk of developing lung cancer, not surprisingly, because they're damaged to their lungs. They're at increased risk of having a stroke. They're at twofold increased risk of having a heart attack, not even when you control for smoking. So that relates to their genetic profile. They're also at increased risk of developing metabolic syndrome. So there's an overlap between these conditions. So it's not surprising that when you actually come to look at your COPD patient and make a diagnosis, that they might have, you know, obesity, obstructive sleep apnea, gout, congestive heart failure. So they end up with having multiple comorbidities, which need to be well managed as well if you're going to try and manage their COPD better. And this is really critically important, self-management and education. So it's great to share the platform with Nicola and Sarah, because our job is really, as you'll see, is quite simple from a doctor's point of view. It's easy to make a diagnosis and to target therapy. It's more difficult to teach self-management skills and to get the patients to understand their condition better and implement the strategies more effectively. So when you're going to assess a patient, Nicola and Sarah are going to talk about methods of evaluation, and I'm not going to spend too much time on this other than to say that there are formal ways of evaluating people's exercise tolerance or intolerance. There are questionnaires, but there's functional approaches as well. You cannot manage inflammatory airways disorders without spirometry, and we need to spend some time on that. I'm going to tell you about why airway inflammation is critically important, but it's also important to think about these other things, whether they're colonized with pathogenic bacteria and how that might impact on your treatment, and whether they're mucus hypersecretors or not, and of course if they're getting more severe, whether or not they're desaturating or becoming hypoxemic and requiring oxygen therapy. So how are we placed in terms of these important evaluations? Well, the last time I assessed this about 10 years ago, only about 50% of GPs actually had their own spirometer, and half of those were fairly simple Pico 6 ones, which was measure FEV1 over FEV6 without a flow volume loop, and only half had a flow volume loop. We published the first study of evaluation of spirometry in general practice as a part of a formal study where we randomized GPs to just receiving a DVD with their handheld spirometer, which had quality prompts built into it, versus a 2-hour workshop. And we found that those who went to the 2-hour workshop did better, perhaps not surprisingly, than those who got the DVD, but still only 60% achieved American Thoracic Society standards. But if you look at the literature subsequently, if you conduct a workshop and then go out and evaluate the performance of GPs or their practice nurses in the field and evaluate 10 consecutive flow volume loops and get them to achieve the standard that you're looking at, you can actually achieve the same standards as respiratory physicians achieve, which is about 80%. And even in the laboratory where you're trying your hardest to get people to conform to do things right, but for various reasons, you can only get about 88–90% of people achieving it. So we're going to try and upskill GPs in South Auckland, and we're going to use the physiologist at our lung function lab to sort of basically get people up to this level, because that is critically important. Now, not every GP needs to do that, but I think you need to work within your groups of GPs to work out whether you're going to upskill yourself with your nurses or whether somebody down the road is, and you'll just use a Pico 6, for example, to screen for COPD. It requires collaboration and working potentially or preferably with your base hospital to work out how you're going to get spirometry more uniformly used and how you achieve better standards. So why do we measure FEV1? Well, I think it's a very, first of all, the diagnosis is based on FEV1 over FVC. You have to have a ratio of less than 70% and an FEV1 of less than 80% to conform with the criteria for COPD. Interestingly, FEV1 remains still the single best predictor of mortality in population-based studies, but if the lower the FEV1, the more likely it is that you're going to be troubled by breathlessness and functional limitation, and you're going to have a worse quality of life and more exacerbations. So it's an important thing to measure, although as you'll find from Sarah and Nicola's presentations, once you've got a diagnosis, these other tools that are now available are pretty good at helping you direct your therapy and your management better over time. The other things that are really important in terms of the multidimensional assessment is obviously to look for whether they're smoking or not. In our surveys, between 10 and 20% of people with COPD are still smoking, and we've got to keep trying to do better because that's the single most important thing you can do. Probably the biggest factor in terms of outcome is their nutrition. People who are malnourished, as you'll find out, important to identify those. Also important to identify those who are obese for the reasons I've mentioned. They've got an increased risk of obstructive sleep apnea, and if you're overweight, then you've got a greater risk of having inflammation within your airways. And the reason for that is that cytokines that get stimulated within the immune pathway will attach to adipose tissues, to fat cells, and as a consequence of which they are more likely to stimulate protracted or prolonged inflammation within the airways. You need to also think about the assessment of exacerbations, and you can, of course, these days, you can look at exacerbations in terms of ED use and hospitalization if you want to look at it from a larger perspective. But it's really important also, and hugely important, as you'll find out, look at inhaler device use, whether they're using the inhalers properly. And just a point to make here is that if the more inhalers that you prescribe them, the less likely it is that they're going to be able to use them well. And so keep it simple is the bottom line. And you need to have somebody dedicated to looking at inhaler technique, because poor technique is very, very common, and probably between 30 and 60 or 70% of people are not taking their inhalers as well as they should do. And poor adherence, as you'll find out, extremely important as well. The other thing is, as I've mentioned already, this increased risk of having these other comorbidities. Really important to look at their comorbidities and also to think about them. So if somebody's diagnosed with COPD, do a screen for uric acid, look at their cholesterol levels if you haven't already, and think about the possibility that they may have some ischemic heart disease or increased risk of stroke or peripheral vascular disease, because they tend to group themselves together. Look for their hemoglobin, look to see if they're anemic, because that's going to contribute to breathlessness, or polycythemia, which would suggest the need to look at their oxygen status. I've already mentioned anxiety and depression and these other things as well. Dysfunctional breathing, Sarah's going to talk about that as well. And this is just making the point to you, this is actually a group of patients who had purportedly had lifetime asthma, who then went on to develop COPD and who are aged greater than 65. And this is looking at the risk of other conditions, and you can see they haven't been screened as well as they should have done, because actually there was evidence of emphysema or chronic bronchitis in 25%, so I don't know how well screened out the smokers were. But you can see that they're more likely to have sinusitis, that's not surprising. They're more likely also slightly to have diabetes. This is the metabolic syndrome. this is and a greater risk of that. So this is even non-smoking, purportedly most of these people are non-smoking asthmatics who develop COPD, osteoporosis of course, and cancers wasn't an increased risk of that in this particular cohort. So just to sort of finish off my sort of overview to start the day, this is I think what we're really trying to achieve. Certainly this is what we're trying to achieve at Manukau, and Candy's Manukau. And that is, at the moment, we have high levels of admission rates relatively in New Zealand across most conditions. And the only way we're going to actually achieve a reduction in that is to actually make the care more sophisticated out in the community. So it's really important that you come to meetings like this and that you go back not only and reflect on your own personal approach to treatment, but also to look at your colleagues as well and look at how you might, as a team, better approach patients who have chronic medical conditions. So we need to start diagnosing asthma better and diagnosing bronchiectasis earlier and diagnosing COPD earlier. We only diagnose about 30 to 40% of patients who've got COPD because we're not screening them effectively, we're not using spirometry enough. But if we diagnose them earlier, we would obviously look after them better and stop them from coming into hospital by immunizing them, etc. We can then start developing their self-management skills. We could see them more regularly, hopefully in our practice, to manage their different conditions. And by doing so, you'd flatten this curve out. But once they come into hospital, as Sarah will talk to, it's really important to concentrate on things that actually reduce hospitalization, and rehabilitation actually is one of the biggest things, most effective strategies in terms of reducing rehab. And also we need to reflect on this, is that some people, of course, despite our best efforts, are nearing the end of their life and need advanced care plans. So this is just a health economics appraisal, which I quite like. It came from the London School of Economics. It's looking at the cost effectiveness of interventions in COPD. Here it is, the most cost effective thing that we can do for COPD actually turns out to be annual flu vaccination. Yet when you evaluate it, only about 50% of patients with COPD are getting the flu vaccine. And remember, there's half of the people who've got COPD don't know they've got COPD and probably aren't getting it at the current time. That's really important because flu vaccination reduces exacerbation rates by about 24%. And if you can reduce the exacerbations, you reduce their loss of lung function, the rate of loss of lung function, and you help sustain their quality of life. Smoking cessation is obviously important, but it's not the most cost effective because by the time you develop COPD and you're still smoking, you're a fairly dedicated group of smokers, and so your ability to get them to stop smoking relative to the effort isn't as good. Pulmonary rehab, I can't state that more strongly enough, so it's great to have Sarah here. Really, really important and really cost effective. More cost effective than a LAMA, more cost effective in turn than a LABA, and a lot more cost effective than adding an inhaled steroid, and I'm going to talk about that later today. And here's what we're doing at the moment, we're putting robots in the home. That's the least cost effective thing you can do. But I think what we've got to try and do is to achieve more cost-effective telehealth type strategies. So I think we can do that, but at the moment it's pretty cumbersome and costly. That's just to make the point to you again that smoking cessation is important. So here's what happens. We reach our peak when we're 25, we sustain it for 10 years, and then we gradually decline. This is us if we're normal. By the time we get to 100, we're about 50% of what lung function we had at 25. But if you're smoking and you start to lose it and give up smoking, you tend to start losing lung function at the same rate as the normal population. But if you're on this curve here, you're on a road to self-destruction if we can't get you to stop smoking.
Excuse me, can I just ask, you know, this at 25, it's, your lungs are full. Is that even, because I always say even if you've been smoking as a teenager, does that affect it or not?
That's a very good question. If you the earlier you start smoking, the more impact it has on your lung function. So the kids that start smoking when they're 12 will end up with lower lung function than the people who start smoking at 22. The airways are very, very susceptible to damage. And in fact, probably the most damaging thing for the airways is passive smoking in the first 2 or 3 years of life. particularly if mum smoked, if mum smokes during pregnancy, you end up with lower lung function than the kids whose mothers don't at birth, which is quite extraordinary. And interestingly, their children have lower lung function as well, even though they may not have smoked during pregnancy. So it's sort of the genetic modification carries on. But if mum or dad then smoke in the home, then you get another whammy. And what you find is that there's about a third of the kids who are having recurrent bronchitis in early childhood will be having it as a result of passive smoking and as a result of recurrent bronchitis. They're also the group that's most likely to grow out of that trend during adolescence, because they get a growth spurt and their airways get larger, but their airways will never get to the same size as the others. And it's particularly their small airways, which I'll talk about later on, which are most vulnerable to damage, and that's the problem for them. So good question. This is just in terms of rehabilitation, just making a general comment about rehab, is that as we all get older, we tend to do less and less activity, and it's really an important thing to concentrate. So it's just reinforcing Sarah's place in the whole scheme of things. And this is just making the point that when you do come into hospital with COPD, some people do because they've got poor self-management skills, or there's fragmented care, or they're too impoverished to go and get some help and turn up late. But for a number of people as well, they're actually in the process of dying. And so it's really important, therefore, to identify these patients and to help to develop advanced care plans for them as well, because they should be having a part to say in what they want to happen to themselves and whether they want to come back into hospital the next time, or whether they want assisted ventilation, or whether they even want antibiotics. And we have a number of our patients on advanced care plans, and a number of them have said, no, if I have another exacerbation, I'd rather die at home. I'd rather be kept comfortable at home, die in my own home with my family around me, rather than go back into hospital again. I've been there 5 times in the last year. So important. And that's just making that point again, is that if you look back 30 years ago, then something like 70% of people died relatively suddenly, or with 1 or 2 or 3 weeks of symptoms. It's the opposite now. 70% of people die what's called a sort of dwindling death, and we see that in our parents, is that they start to lose their functional status, and it's a gradual decline. Then they have these dips down, during which time they lose capacity, lose their self-confidence, and that's why it's really important to try and get them back up here again, and why rehabilitation is so obviously important. So this is just the usual goals. This is sort of a underpinning point for the day. Let's treat the right patients with the right treatment and medication at the right time to achieve the right outcome. And just to remind you that if you're talking about COPD, to the patient, let's think about it. What's the patient's major concern? Their 2 major concerns are breathlessness and the effect that that has on them and on their functional status, but also they're scared witless about exacerbations, because they know that every time they have a flare-up and a bad attack, they get knocked back and they never recover their health again afterwards. So they want to work with you to try and prevent exacerbations. So that's our goals. Try and reduce breathlessness and try and increase their activity. And as I've stated, Sarah and Nicola are actually going to have, and nurses are going to have, a large part to play in this. It's not just doctors giving drugs out. We've got to get the diagnosis right and put them on standard medications. But it's important that somebody makes sure that they're using them properly, good inhaler technique, and that their adherence is good. And if they get that, then we can try and maximize the health benefits of that. So if we apply all of those things, it's really straightforward. You just use an equation, and then a miracle will occur. Okay, thank you very much.